So anyway, look, welcome to this webinar. We're really excited to present our second webinar of the series and have Rob Sanson-Fisher, who many of you know, who's obviously one of our leading experts in implementation science. So, for those that haven't joined us before, as you know, we're a series of activities and programs on behalf of the implementation community practice that's organised by the Cancer Institute of New South Wales as part of the Translational Cancer Research Centre. Although we're obviously really welcome anybody else that's not necessarily directly involved in those centres along too, because I think we want to kind of raise the capacity across the system in implementation science. Now, on the screen, I hope you can see the upcoming activities that we'd like you to potentially come and join. And you can also see the website link there. So I encourage you to register with Charlotte, who's the driver behind these activities, so you can actually take part. So look, given that we've been a bit slow, I won't say much more. I'd just like to introduce Rob. Really looking forward to hearing what he's going to be talking about. So he's talking about when, why, and how should we do translational T3 research. Now we're just going to just in housekeeping, as you know, we have quite a large number of people registered for this webinar, which is great. What that means is we're not going to let people ask questions with their voice, but we certainly encourage you to go into the question section on your webinar screen and type in questions for Rob. There's an audience also in Rob's end, so people will be directly asking Rob questions within there. We're going to use a roving mic so that everybody can hear the questions that are being answered. If you do type in a question, then one of the team will actually ask that to Rob so everybody can take part. Is that all the details you want? So now we're going to try and switch over towards Rob. We haven't actually done one of these where we're switching it between presenters, so there may be just a short delay while we do that. Thank you.
Okay, so what do we do now?
Okay, Rob and Melissa, we should have just handed over to you. So hopefully everybody can see your screen, and I think I could see Rob standing up there.
Yes, I think we've got that. I must admit to being very nervous about doing this. I'm grateful to the people that are in the lecture theatre here with me. It's quite interesting to think of people sitting with cups of coffee, which I would really like at this moment, and watching. But what I'd like to do is talk about four things, and I hope you can see these on your screen. And to sort of break it up and just to make sure that we've got some contact, I'd like to provide an opportunity for people to ask me questions after each one of the four areas that I'm talking about. When you're talking about implementation science, I think often there's people forget that the first really important step in this process is establishing that there is evidence, which is strong evidence based on well-controlled trials that show that we should be doing something in the community if we're to improve well-being for our patient groups. Usually the demonstration of evidence is that there should be multiple well-controlled studies demonstrating an intervention effect has had a positive effect. That idea that there be multiple trials comes from NH and MRC, but it's also part of NICE, NIH, and NCI in America. If you look at Cochrane reviews, it's a depressing factor that every time you go to a Cochrane review on a particular topic, if you want to look for something, see whether, for example, smoking cessation works with pregnant people, see whether or not we should be doing shared care, the usual sort of response you get back from a Cochrane review is that there's not enough research being undertaken in the field, that research that has been undertaken is often methodologically flawed. And just to emphasize, when we're talking about research, evidence is derived not from descriptive studies. That's correlational data. That just tells you that you can generate a hypothesis. Evidence is derived from intervention studies, and in particular, well-controlled intervention studies. Until you show that if you change something that produces a positive output on a positive outcome, you can't really say you've got evidence. So you'll actually notice that a lot of people, when they're talking in seminars or in sessions like this, they'll say evidence shows, and then you go back and you look at what they're using as evidence, and they're showing descriptive research, correlational research. That doesn't constitute evidence. It's indicative that something might be occurring, but it doesn't show that it will occur. Often in these studies, the populations that are selected for study are very restrictive, so you can't apply it to a wider population group. And often the interventions, particularly in the area of health behaviour science, are often so impractical that you couldn't replicate them in ongoing clinical care. So just to give you an example, you know, we all, I hope, share a view that what we're doing with our Aboriginal community remains to be an appalling blight on how we're effective or not effective in helping a very vulnerable population group within Australian society. Their life expectancy, as you know, is about 10 to 15 years less than European Australians, and across the range of ages, 0 through 45, 50, they have higher morbidity than European Australians. You would think, therefore, that there'd be a huge number of interventions trials trying to make it better for Aboriginal communities. And I hope that you can see this slide shows that was done by Chris Paul and our group. And I'm going to talk mainly about our research, not for any egocentric reason, but just I know our research better, and we'll be able to answer questions. But there are very few intervention trials. That goes across Canada, US, Australia, and New Zealand. And of the intervention trials, very few, only a few met EPOC criteria, that is the Cochrane Review criteria for what constitutes a good study. So what we have is repeated efforts or repeated activities by researchers, myself and others, and we keep on telling Aboriginal people, gosh, your health's bad, you die quicker. They already know that. What we don't tell them, and we say, let's do something with you, and they say, well, you're the experts, show us what works. And we can't, because we don't do that research. You know, I find this sort of, if people have heard me talk before, I find this quite an appalling situation to be in. You'll also find that often the studies that have been done don't allow you to replicate it. And by that I mean, if you take smoking, so there's 30 trials that have been done with try to reduce smoking amongst pregnant women. This is work by Jamie Bright and the group here again. And if you're going to follow those studies, you need to know specifically what was done to get the treatment effect. You need to know what happened. The orange colours, these colours, by the way, represent my colleagues who have got skills at putting together PowerPoints. But I must say I like the orange and I like the red. So I really appreciate it. But if you just go to the end there, if you go to the behavioural counselling approach, which is, so you've got 30 trials showing differential treatment effect. If you're going to replicate this, if you're going to give this to O&G or nurses or whoever and say, this is what you should do, you'd want to know specifically what the intervention was so you could duplicate it and get the same treatment effects. So there's a real difference between saying you smoke, you should quit, versus saying, I see you smoke. Smoking is really a really hazardous thing. The most important thing I can do to help your health is to get you to quit smoking. I'd really like you to quit now. And which one of those will get a treatment effect? I'll go for the second one, but we don't know what the intervention trials are. So that as a consequence, it's hard to replicate it. So if we just pause at this, what I'm saying here is that you need evidence, and you need evidence that you can replicate in the clinical environment. Consequently, there's too few intervention trials. You can't generalize in the health science from international studies. What works in America may not work here. What works in England may not work here. Different healthcare system, different social environment. And I think it leads to a debate about whether we should be allowing researchers such as myself to do whatever research they feel like doing, or whether it should be strategically directed research. We should say, this is the research we need to be done. For example, in Aboriginal health, don't tell us again Aboriginal people are sick. show us how you can make a difference. Do intervention trials. I was going to pause here, but I'm frightened actually of the communication pattern. So what I'm going to do is change what I said and go on to the next one. The next area, so let's pretend that you've got evidence that something is effective. There's actually an array of evidence. You know, like, should you do something about smoking in pregnant women? If you just take smoking in pregnant women, smoking in Aboriginal people, smoking in general practice setting. You need to decide some way, in a rational way, which one you're going to go after. Often we decide based on our own interests and what we're familiar with, who you can work with. But it's actually most probably better to do something strategic. You need to know where there's an evidence practice gap, and this is actually, sounds easy, but it's actually quite difficult to get. You get that data from medical records, for example, for some areas. You can't get from medical records whether or not the clinician has asked about smoking. Often they don't record it. You can't get anything about psychosocial. Often it's not recorded. But if you're asking about colonoscopies, where colonoscopy's done, you must probably get that from the medical record. Whether the colonoscopy is done for the appropriate patient is difficult from medical records, because the doctor who writes it in will not most probably write in the information that allows you to decide whether the colonoscopy was done for a patient who met the NHMRC criteria for a colonoscopy or was a worried well patient. Really quite hard. Health insurance data gives you the same sort of data sets, often difficult to access. And then you can go to self-report for both patients and providers, and both of these are flawed in terms of whether or not you get accurate information. So it is a real problem with getting information about what is currently going on in the clinical environment. If you look at the area of oncology, one of the other things that happens in any field is often our clinical colleagues believe that if there are guidelines, they all do it. And the only way you can assert whether or not that's the case is to do studies. This is the number of studies that have been undertaken in oncology in 2000, 2005, and 2010. And as you can see, in 2010, there's been a gratifying increase in the number of studies that have been undertaken. This is across all areas of oncology. That is, if you go with a cancer, do you get evidence-based practice given to you? And so 88 studies have looked at that. Incidentally, a third of those studies are in breast cancer. So they're not spread evenly. They're actually reflecting again where there's interest by researchers and demands of a strong patient group. And you can also see that the number of trials that have been undertaken to improve that is quite limited. That's the orange there. So actually, we don't actually often know whether or not we're getting evidence-based practice because we don't do the studies to find out whether or not they should occur. If we were getting it, rather than basing it on our own self-interest, we'd most probably determine which areas we worked on the basis of it's prevalent, that is, it occurs a lot. Is there a burden of suffering which is imposed from the evidence practice gap upon the individual, upon the provider, the system, or the society? And you've got to see that it's conceptually possible that you can try to change it. In a rational utopia, we would have evidence from well-conducted studies about the evidence practice gap. And again, you cannot assume from overseas studies. You would need data on local clinical behaviour, because what happens in Newcastle may not be the same thing that happens in Sydney, or may not be the same thing that happens some other part of Australia. You need it on both technical and psychosocial areas. Your quality of care is not just technical, it's not just psychosocial, it's a merging of these two things. So you need data on both of those. Technical is easier to get, psychosocial much harder to get. And you need to define the area by data, legal, and sort of social justice issues. It shouldn't just be on your basis of your issues. Can I perhaps pause there, and I'm going to ask the audience here first to see if there's any questions about any of those two things. And I think if there are people who are listening, they can send by email. So just any comments or debate about the two things, establishing strong evidence and selecting the evidence practice. Yeah. You've got to ask me a question, otherwise I'm going to get really upset. So I'm going to pick on the people I work with. Heidi asked me a question. And Heidi's just put her head in her hands and she's crying. So, you know, I'll ask Alex. What do you think, Alex? Any questions? Okay.
Do you want me to ask you a question?
I do.
How specifically do you think that you should approach the diversity of clinical settings? Because there's going to be infinite number of different clinical settings, and it seems like it's quite difficult to decide on an approach that might target the majority of them.
Yeah, so the question was about, if you correct me if I'm wrong, about the fact that there's diversity in clinics, treatment centres, also diversity in individual clinicians. And you know, what do you do about that? How do you put in an intervention? I think I'm going to come to that, but I actually think that the issue is you should treat treatment centres as unique identities. And by that I think that you should use, like we use for patients, stepwise care. You should try something which is cheap and relatively economic for all treatment centres. Some will respond, some won't respond. You know, some will get better, some will stay the same, and some might even get worse. There's always three potential outcomes for any interventions. With the guys that don't shift, and with the guys that get worse, I think you target them with an increasingly complex or more costly intervention, just like you would if you were dealing with somebody with high blood pressure. You know, diet first doesn't work. It works with some. Then for those that it doesn't work with, perhaps more intensive effort to try and get diet to shift and exercise, and then you might shift to drugs, and then drugs get more complex. So I think you stepwise care. So you think of you don't ever think that everyone's going to respond. I think one of the interesting things about this field, about implementation science, is I'm not sure if I'm going to explain this too well, but when we talk about patients, we have a language and a way of thinking about it when we think about stepwise care. When we think about changing evidence practice gap, it's sort of surprising that we forget clinicians are humans and they respond or don't respond in the same ways, and treatment centres are the same. So I think you need to use the evidence which we've got from patient change and apply it to evidence practice change. Sorry,
so we've got one online question from Tim. So Rob, that's an interesting idea regarding not having investigator-led trials. Who should set that strategy? Is it a role for the Cancer Institute?
I think it's the trouble with having friends who are listening to you and asking questions. The debate between investigator-driven and strategic research is one which bedevils the field, both here and overseas. You know, it's been a lot of conflict, and I think that the people who set it in the cancer area, for example, should be the Cancer Institute, and it should be derived from not vested interest, but views about what will give the greatest gain to the community and where the gaps are. The things that I mentioned before, those criteria, prevalent, big gap, conceptually possible in shifting, that should influence where the decision is made. And I think that will be very hard because investigators, researchers are quite, in some ways, self-centered about their own particular field, and so it'll be quite hard to shift them into what is a common sort of view. NH and MRC was also found the same trouble, but I think that some proportion of our budget should be strategically driven. One more question.
So another online question from Megan. Can you explain a little more about the psychosocial aspect, say in relation to smoking cessation care?
not sure what that might mean. But I think the point that I was trying to make, there's lots of things about both psychosocial and smoking, but I think I was trying to argue that researchers are failing those interested in implementation science by not giving enough detail about what they do, not having manuals, not having videotapes, and saying, this is what I do. You know, if you're talking about communication skills, for example, it's not enough to say, pick up cues. Show what a cue is, show how to respond, show what to do about it. You've got to be detailed in it. We would not accept if a surgeon said, you've got to operate on this part of the body without being very, very specific about how they should do it. We should apply those same rules to the field that we're working in. I'm going to move on. One of the things when you come into this field is the field has actually been there for a long time. That is the quality assurance and what we should do. Medicine has got a long and I think justifiably proud history of trying to ensure that they provide postgraduate and undergraduate education. So if you watch Four Corners, you hope without bullying or without sexism. And these are some of the ways that people believe that you can change provider behaviour. Now, these things have come about, or these ideas have come about, often as the consequence of very strong advocates. CME, for example, continuing medical education, has been there for a long time. Is it a good idea? Absolutely a good idea. Does it change clinical behaviour? Well, there's a limited number of studies, and those that exist show that it doesn't change clinical behaviour, and the people who come are not the people who should be wanting to reach, but we continue to do it. So one of the problems in implementation is the passion and the advocacy of people who believe that these things work. And some of them work and some of them don't. And that's what implementation science is about. You get evidence, and then you need to find ways of getting it adopted, and it's science. Some things work, some things don't work, and you need to test the effectiveness. Most people think that implementation science is, many people, sorry, think it's getting evidence stuck from studies on patients, and then the next phase is how do you get everyone to do it. But they don't think that this bit should require science, but it should, because otherwise we're going to waste our time on some of these other activities. And I'd just like to give you a couple of examples. One of the common sort of beliefs is send it to clinicians and they will change. Because of course they're good people, and they are. They care about their patients, and they do, and they want to make a difference, and they do. But there's obviously, clearly, from all the data that we have, not all clinicians respond to the guidelines. They just don't. We know that there's huge gaps. And I'll just give you a study, which is one of the biggest that has been done, and is another example of my failure in the area. You know, my CV represents me trying to do things and not succeeding. But this study came out of 12,000 general practitioners here in Australia. And I was working with NICS at that stage, National Institute of Clinical Studies, and the government, federal government, said, what we'll do is we'll purchase B&J clinical effectiveness and give it to every general practitioner in Australia, 24,000 of them, and that will get evidence practice gap reduced in general practice. This wasn't without cost to the Commonwealth. You know, I think it was $100 or something that they're going to send about. So it was a big thing. So we said to the federal government, look, it's a great opportunity to do implementation science. What we're really interested in is to see whether or not general practitioners, when they read B&J, Evidence Practice Gap, which is a summary of the best literature in the field on a huge number of topics, whether patients get better care. So we were interested in, did clinical care improve, and in particular, did patient outcomes improve? But then we said, well, you've got to see whether or not they'll accept it. So we randomly allocated 12,000 general practitioners into 6 different groups. And we said to marketing people, we said to College of General Practitioners, everyone you can think of, what technique do you think would be effective in getting general practitioners to accept the offer of the B&J guidelines? So step one in the process. And it was really interesting. There's some of the things that we got, they used. Marketing people were passionate that what they thought would work. College of General Practitioners were absolutely sure that what they recommended, that is endorsement by the leaders, sending out things, using local contacts would work, so on. So everyone had a view, everyone was passionate, and none of them were right. There was no significant difference between the 6 groups in GPs who said, yep, I'll take a package. And if you have a look at it, 12,000 general practitioners were offered it, and 1,228 accepted it. Huge gap between what you thought might happen. And then of those who accepted it, 5% or 580 of them has used it. So 12,000, now we're down to 580. Repeated users once a month, over 2 months, 379. Over 6 months, 65 of them used it. So hardly any, the probability that you're going to get any impact at all on clinical behaviour is zip, nothing. But we would have sent that out to everybody. This is an example of disappointing results in implementation science. So sending it out doesn't work. Give them feedback is the other strategy. Look, if you just tell clinicians or hospitals what they're doing, they'll change. Well, actually, there's 140 trials on feedback. It varies from 0.5, almost no treatment effect, to 16% big effect. In general, it looks as though, now we don't know this, we don't know what affects feedback, but these factors influence whether or not feedback is effective. If you tell people, if you give that drug, patients are going to die, there's a rapid change, massive change. But it doesn't follow that if you tell people about their, say, colonoscopy rates, that they'll change, because a clinician, human being, can sort of say, these are reasons why I'm self-exempted from that feedback. My patients are different. I see all the tricky, difficult ones, which is what a hospital says. That's always say, we're not getting, because we've got more. They self-exempt on the basis of the patient, or they self-exempt based on their own reasoning. Doesn't follow, there's no data, no strong data to suggest that feedback alone is effective for everything. Let me give you also one quick, this is a study that we've done. We asked patients when they came in to see their general practitioner whether consume alcohol above the NH&MRC limits and whether or not they are smokers. And you check that with biochemical assays. Then you ask the GP immediately after they've seen the patient, if it was me that was doing it, is Rob a smoker? Is Rob a high alcohol consumer? And you can compare, so you can compare accuracy. So the first study we did like that was with a colleague, Jim Dickinson, in 1984. And as you see, they actually detected about 55, 56% of people who are smoking, meaning that 44% of patients who are smokers aren't known by their general practitioners, irrespective of how long they've been coming to the clinic. So that means there's 44% of people who are missing out on the opportunity to get stop smoking, cessation. Alcohol, it's even worse. And it's worse, we think, because it's a much more complex process when you ask a patient about alcohol. It's when did you drink, how often did you drink, what did you drink, and so on. So as a result of those studies and lots of other studies like that, all these things have been put into general practice since the study. I'm not, by the way, in any way suggesting that our study made this happen, but general practitioners and other people said, let's do all of these things. So as a consequence of that, you would expect detection rates to change. There's been guidelines produced, there's been workshops and seminars, there's been practice nurses who are supposedly taking it on. And here's 2 further studies. The Hayward study in 1990, which was done in the Brisbane area, about 110 GPs, same data collection strategies, and a study that we've just finished, this time of 52 general practitioners and 3,500 1,000 of their patients, almost no shift. So the interventions that we've been trying haven't actually changed what providers do. Best ideas, but haven't changed it. And it again highlights, in my view, that we shouldn't have done all those changes without testing their effectiveness first. Test them first, see whether they work, then try to get widespread adoption. But they haven't been successful. So just summarising what I'm trying to say there are lots of advocates for very different strategies of changing clinical behaviour. I think we should be careful about the passion of that and doing more of the science. We don't really know. And one of the interesting and demanding things about implementation science is that in this area of research, the subjects are not patients, they're clinicians. You want clinicians to agree to subject themselves to examination, and you want them to be part of a randomized controlled trial. And you want centres to be part of a randomized controlled trial. And one of the great problems is that it's quite hard to get clinicians to agree to this sort of research. And I've given you two studies, one from general practice. One of the other things that I found is that as you go up the hierarchy of power, general practitioners are the most professional. You get about a 52% consent rate if you go to GPs and say, will you do the study? The first study we did, we videotaped all the consultations, and we got a 52% acceptance by GPs to allow their consultations to be videotaped, and an 85% consent rate by patients. Patients aren't the problem, it's us that are the problem. If you now then go to surgeons and say, can we do your study, your consent rates drop dramatically. You know, that surgeons just aren't too keen on letting you see what they do with patients. So, you know, the studies, many of the studies have been done in general practice, and it leads you to think, well, GPs aren't too good. But you should also think, well, GPs at least are professional. They're willing to do what we think we should do as a professional, expose yourself to clinical appraisal on quality. Perhaps other professions should do the same. So I think most probably I've got question. I could take questions if there's any. I'm not going to pick on you, Heidi, or Alex again. Are there any questions for anyone? I think this third section and the stress that the responsibility for implementation science is a responsibility of us to A, firstly do science, and B, as professionals, to be willing to be a component of that research. That is, nurses, occupational therapists, you know, the whole professional range. If we are professionals, it's obligated on us to say, yep, come and see me, come and see what I do, and I'm willing to be part of a randomized controlled trial. This is not something we should just be arguing about for looking at patients. So lots of studies showing that patients should be recruited. There should be an equal number of studies showing providers should be recruited. I'm getting nods for those who are sitting at home with their... Any questions?
So this is an online question from Natalie. You talked about testing interventions and replicability. How can you test multifaceted interventions in complex healthcare settings in a way that allows identification of effective components and therefore replicability? Is it realistic to do randomized controlled trials, or do we need to choose more pragmatic methods?
I don't know who you are, Natalie, but that's really good. That's what I'm going to actually talk about next. So if I just take the first part of the question, which is the business about so-called component analysis. So if you've got 5 intervention strategies, and this goes back to Nick's question, you try the simplest and most cost-effective first, then you move into the others. Now, the question is, you know, so when you do an NHMR review, or when you talk about studies, people often say, well, which bit works the best? It's a fair question. The trouble is that we are so inept at changing providers' behaviour that I don't think we're at the stage yet where you can say, was it feedback? Was it peer support? was at journal clubs. I think the first question is, can we get change? And that's what we do with a patient. You know, like patients who are really sick, you use every strategy you can think of to try and make it better. You're going for a change. And when you think about some of the early studies of antibiotics, for example, patients were really sick. They take frequent measures of temperature and they threw everything they could at them. Well, actually, they didn't. The first couple died, but then they got better and they started to throw everything they could at them. So the question is, can you get change? And I'm going to talk about that in a minute. So I think that in this area, the question ought not to be about component analysis. The question ought to be about mission. Let's get change, and then when we've got change, let's do component. You know, it's too important to be fiddling and saying, is it this or this? It's cost-effective issue question, but the first question is, it's so hard for us to get change in a time. It's estimated that there's something like 15 years between evidence and adoption. And when you talk about adoption, that gap of time is not only about adoption, but it's not 100% of people are adopting 15 years later. There's still a significant proportion who are not adopting. So I think we should be trying to shrink the time and increase the number. Sorry. Yes?
I'll ask a question. The same one of the large challenges with implementation science research is attaining provider consent. Are there any strategies that you...
Yeah, I think, thanks. Sorry, the question is, what about consent? And I think the way we've set up is to do patient intervention trials. But when you're doing provider intervention trials, you need, say, 20 treatment centres. And you go to treatment. My colleagues would tell you about the hazards of doing multi-centred trials. You go to treatment centre 1 and they say, for ethics, and they say, this is the ethical question. You go to treatment centre 2 and they say, oh, no, there's a different ethical question. And not only is different information that you're getting back from those treatment centres, but you're also taking a huge amount of time. We can, I'm going to have a nervous moment here. I think it's like 1.5 years to get agreement for a naturalistic study, descriptive study, across 17 treatment centres across Australia. 1.5 years for ethics, you know, and that's cutting into your experiment time. It's also sort of frustrating, you know, like it's not just about money, it's just not about ethics. We should speed this up. We need data quicker and faster. Sorry, so one, and then...
just in response to that, Rob, is not a great issue the engagement of the clinicians and the settings in which they're working. And how would you suggest that we go about engaging them so that we don't have such resistance?
Yeah, so the question is, how do you get provider engagement? I think, and we're going to try this, but I think you need a community of practice. And the community of practice says to you approach clinicians and you say, guys, would you agree to be part of a community of practice? And would you agree to be either studied 3 times a year with 10, 15 patients, and you can be involved in setting up the decision about what the what the trial's about and all that sort of stuff. But would you agree? And obviously, I'm going to say this fairly coarsely, but I think you'd sort of say this is part of your professional responsibility. You know, don't just give us patients, give us you, and we want 200 of you. And the commitment is to work with researchers in a collaborative manner, but to commit to so many studies per year. And they might say, you know, you might say, would you commit to 1? But you can commit to 3 if you like. And you can do it every year. But if we're to harness the potential between providers and researchers, you need to know that you can access. Access currently, as you're pointing out, is extraordinarily difficult to get. You know, like Nick, as a colleague and a friend, I work with him because he trusts me, I hope, and I trust him. But you're going to patients, providers, and you're asking them to trust you, and they're often not that keen to trust you for good reasons. Often you show that what they're doing is not too good. But the interesting thing is we ask patients to trust us, and they do, and we actually sort of demand it. Same rules, in my view, should apply. Sorry, another question.
Just one more question. This one's on the same topic. So as students, clinicians are assessed regularly through observation. Has there been any work in interventions to build clinician willingness to have their practice observed and participate in implementation interventions?
Sorry, that was a question from Megan. I think I've just answered that question. And what I'll do now is I'm going to talk about trials, because there was a part of the other one was about randomized controlled trials. If you're doing implementation science, if you're doing evidence-based science, you need to answer 3 broad questions. They're simple questions, but they're hard to do. Firstly, has change occurred? Was there an improvement? Or did it? And please, if I leave you with one thing, always think it could get better, it could stay the same, or it could get worse. Sometimes it gets worse. And we assume that because we're caring, because we're trying to do the best we can, we always assume that our product is going to make it better, but it doesn't. Just lots of data about this. Did the change occur as a result of the intervention? Not did the change occur, but did it change as a consequence of what you did? Not something else, but what you did. And then, is the change significant or important? This area, the third area, is actually becoming much more controversial. So scientists for a long time have said, well, whether or not it's significant is defined by a p-value of 0.5. But there's starting to be quite a lot of debate now about whether p-values are what we should be using. Is it enough for a statistician to say to us, you've got treatment significance? Or should we be saying, no, I'm defining significance in 10 people saved or 50 people who have shifted. Now that's got cost implications, cost effectiveness. But when you go to politicians, they're going to have a different view. They're going to sort of say, has it got significance in terms of publicity? Has it got significance in terms of taking resources from over here? So the definition of significance varies according to who you're speaking to. So in my area, I'm usually talking to colleagues and epidemiologists. By the way, increasingly in ministries of health now, as you bring your evidence in to the Department of Health, and an epidemiologist will review it. And then it might get to the minister, and the minister will sort of say based on the epidemiologist's view. So there's a filter often in the system, but it's often methodological and often Cochrane reviewed, but not always. The R.C.T. that somebody's just asked me about is the gold standard. Basically, randomly take a group of people, randomly allocate them into experimental and control group, try to control for bias. The problem with the randomized control trial, or what we've seen over the last perhaps 2 decades, is an understandable, desirable demand for evidence-based practice in clinical medicine, and that's to be applauded and supported. And the gold standard for that is seen to be the randomized control trial. And the gold standard randomized control trial works really, really well when you're talking about patients. But human behavior, we know, we used to think Freudian or Jungian or operant condition, which is very individual. Now we think it's really hard to get a change. You need to change the individual, you need to change the environment around them, you need to change the system in which they operate, you need to change everything. So that's the idea of no components, but mission orientated. And when you're doing that whole system approach, then randomized controlled trials means you've got to take the whole system and randomly allocate it. Now you can't do 100 or 200 and 200, which you can with patients. So we've got a trend towards evidence-based practice, randomized controlled trial, and a perception, and I think common agreement, that if you're going to change behaviour, you need systems. These two things are in conflict, and the randomised control trial doesn't stay us well in the area of implementation science. So we need other designs. And the variant of the randomised control trial is what's called the cluster randomised control trial. Basically, you do exactly the same things, but now you're taking clusters. And the cluster could be a treatment centre. So we're doing trials, for example, with hospitals, trying to get them to adopt thrombolysis treatment, 10-10. We're doing trials trying to get, Chris Paul and Sandra Eads are doing trials where they're getting AMSs, Aboriginal Medical Services, to do something about better care for diabetes patients, 10-10. So the cluster now is the unit of analysis, because clinicians are influenced by all the things that I said: individual beliefs, individual attitudes, desire to make money, desire for prestige, the system in which they operate, peer support, peer feedback, and the system which might say to them, we're going to do something about this and we're going to find your feedback. These trials are, we've done one where we've taken communities in New South Wales, 20 randomly selected communities in New South Wales, randomly allocated them, or matched them first, then randomly allocated them into experimental and control. And we did 13 evidence-based interventions and saw whether they worked. This is work by colleague Anthony Shakeshart and myself and others. And we found actually a treatment effect, which is quite unusual. Like when this happens, you get really excited because it doesn't happen that often. But cluster randomized control trials are, for the reasons we've already talked about, difficult to do. You've got to get 20 units to agree. You've got to get ethics. They're really costly, and they take a long time. And one of the other things is that you see down the bottom, they actually take a high degree of courage. That's not meant to be a joke, actually. You've got to be really courageous to do this. You've got to say, I'm really prepared to lay myself on the line here and do the best I can, and I know that I might get a null result. And we've done 2 of these big cluster randomized control trials, one with 20 communities, again, looking at cancer. We didn't get any treatment effect, and if you're an academic, it was hard to get it published because it was not a treatment effect. No one quotes it. You don't quote negative results, and most disturbingly, it couldn't convert the findings into airline tickets and go and talk about that at a conference. So no one wanted to hear about it. And you committed for like a 5-year period. You're just in there, and you're really working hard to get a treatment effect. And the other thing about going back to the component analysis, you don't know which bits are working. You're just trying to get an approach, and you don't know which is going to make a difference. So you don't actually know. In one of those studies that study that I mentioned, we tried to get GPs to change. Had no idea whether we were changing. It was really hard to get a monitor of them in 20 towns. So you didn't know whether it was happening or not, but you also didn't know whether you're going to get a treatment effect. The other strategy is step-wedge design, and this is a model that I think many of us could use. We're using it, and I'll talk about that in a minute. Basically, you can see that there's 2 pairs, in this case, 2 treatment centres. You do a pre-test in both. You do the intervention then in one pair, and then you do the post-test in that first intervention trial, and then you do the pre-test. I think that's fairly clear, but it doesn't require 10-10. You can do it with smaller numbers. It's got the same problem as a cluster randomized control trial. You don't know whether the treatment effect is working. So you can't. The good thing about clinical practice is, and clinical practice gives you a lot of guidelines. If you're really sick and you're in hospital, you're getting your blood pressure and your temperature taken all the time. They give you intervention A. If there's no treatment effect in a short time, they give you intervention B. The trouble with cluster randomized control trials and step wedge, you put the intervention in and you don't know until the post-test whether it works. So it's a high-risk intervention. I was going to talk about what we're doing, but I shan't do that. So the step wedge is smaller numbers, less complex in terms of running, much more complex statistical analysis. The design that I think works best in these, by the way, are all epoch accepted designs. So this is not Rob Sanson-Fisher, they're all in epoch. Is multiple baseline design. And the reason why I think it's good is you can see that you collect baseline. Let's say we take hospital 1 or clinical group 1. Then you get baseline data, you put in your intervention, and you do it at a staggered time for intervention 2. So two hospitals. But the good thing about it is you're getting continuous measures. If you get continuous measures, if it doesn't work, if the first intervention doesn't work, put in the second intervention. If that doesn't work, put in the third intervention. You keep on going till you get a treatment effect. And I won't talk about that. And that's actually the finish of the talk. I've just got to wind up anyway. So, so just to sort of summarize, I think I'm trying to hopefully convey to you that we ought to think we firstly need evidence. And often we don't have evidence. And so you have a lot of passionate people saying, I think we ought to do X, but no evidence. So less passion, more good science, because we should be here to care for people, not about self or ego. Secondly, that the issue that we should address should be determined on a priority system if you can. In oncology, which I know more about than other areas, which is the thing that would really make it better for patients? That's the one you should do. You should try to overcome the resistance or the problems in it. You should go for that, not your interests, but the things that will make it better. So it shouldn't always be breast cancer. Breast cancer gets more attention than any other. What about colorectal? What about lung? You know, it should be determined not by the passion, but by need. You should use implementation strategies that have got demonstrable effectiveness. And finding for that is you don't know what they might be, and you need to do science. If you're going to do science, do the best you can, which means that you don't usually do it by yourself, you usually do it as part of a multidisciplinary team. Few of us now have got the capacity to do this sort of research as individual cottage industry or renaissance people. Researchers need clinicians, clinicians need researchers, collaborative relationship, and you need clinicians, you need health behaviour people, you need health economists, you need biostatisticians at a minimum. You know, this is not just do it whenever you feel like doing it. This is like any other task, and we should be doing it. And so I think that's the end of my presentation. If there's any questions here, or I think we've got time, have we? I'm glad there's an audience not here, you know, guys. You know, you're pathetic. Questions.
So, online question, there seems to be limited stats expertise in analysing step-wedge designs. Could we organise a webinar with someone at your end who is expert in this area, please?
Yeah, I think I think that'd be for Tim to decide. But I think there's so one reason why we actually are having trouble doing good studies in implementation science is sometimes you ask a question and then you say, what's the design that I can use? And often you think, if you're a scientist, you think randomized control trial. I think the better way is to say, what's the intervention which I think will work? And then say, what's the design now that will be able to answer those three questions? Did change occur? Was it as a result of the intervention, or was it significant? So rather than the design determine what you do, you should let the intervention determine what you do, and then find the expertise to do the evaluation. And step wedge and multiple baseline are not well understood. You know, conceptually they're easy, but statistically they're quite difficult. You know, we're finding our way with them, and it's because implementation science is also finding its way. So I think it would be a good idea if Tim would agree to sort of talk about the stats, but to be honest, if 20 people said to me, should I attend that seminar, I'd say, I don't think you're going to understand it. I don't understand it. What I do is I put my arm around a colleague and a friend who's a good biostatistician and say, work with me on this. Don't have to be expert in everything. So it's the idea of working together rather than thinking you know it all. The stats bit of our studies, for example, step-wedge and multiple baseline, we've got great statisticians who work with us and help us, but they help us at the beginning and throughout. We don't call them in to take meaningless data and try to convert it into a paper. They're there at the beginning. The whole team's there at the beginning. Yep.
Just on the idea of design, I quite like the step-wedge design, but it's multiple baseline design also has its pros and cons. And the one thing that does come to mind is the concept of contamination.
In both?
Well, in both, yeah.
Yeah, it does.
Which would you suggest would be the way around that?
So the question is about contamination in the design. Contamination is a real issue. That is that you put it in the intervention in here, and somehow or other it spreads to your control group. It's there for randomized control trials. For example, the cluster randomized control trials on thrombolysis. If you intervene here, how do we stop it spreading to Sydney? People talk, clinicians, as they should, as we want them to. They talk about it and they say, we're doing blah, blah, blah. Contamination is always a problem. In the trials that we did in communities, we said that the communities had to be, I hope I'm right about this, 150 or 200 kilometres apart. Now, does that stop contamination? Well, it might, but might not. So you might get untoward effects. Multiple baseline design, on the other hand, I think is easier to have contamination control because you're putting an intervention in, and pretty much it's limited that treatment centre. So you're actually seeing there's a treatment effect. So I think it's like a methodological problem. And again, when you start back here with all your colleagues, you sit and you think about it. But one of the issues is what intervention do we want to put in? What do we think might work? Who can we work with? Then the question is now design, not the other way around. If you want NH&MRC, it's quite hard. We've got NH&MRC for multiple baseline design, but it's not really yet accepted. By that I mean randomized control trial, everyone knows and understands. So often reviewers for NH&MRC get a bit cautious about multiple baseline and step-wedge, but I think that's changing.
Just on that though, would you be able to measure the impact of the contamination using that multiple baseline design? Because you can say, okay, well, we've come in at this point and we've basically got that new site on board.
Well, multiple baseline design, you say you're going along like this, with both, say, just two at the moment, put in your intervention community, and let's say it goes up like that. If there's generalization going to occur, it's likely to occur in that period so in terms of treatment output, whatever that might be, colonoscopy, I don't know what it is, you'd expect a little blip to occur, and then it might flatten again. So you can actually see it, whether it occurs in terms of your outcome. Now, they might have, in fact, if you've gone for, say, ward rounds as an intervention, it might be that they're doing ward rounds, but if it doesn't get a treatment effect, it hasn't generalized, if you're getting it in the other one. So you can look at it. It's hard to answer the question. It's a good question, but it's hard to answer it without the specificity of what you're trying to do. Sorry, I'll take that.
Yep. So this probably follows from that. So can you please clarify the difference between multiple baseline and step-wedge design?
Yeah. All right, so I think the easiest way to do that, so this is step-wedge, and basically it's sort of in some ways like an R.C.T. You get baseline data, you put in your intervention, and then you look at your treatment effect. So it's baseline, intervention, treatment. That's it. The step-wedge notion of it is that you've got that occurring at different times. So you can sort of say, well, the intervention changed. The intervention was a result of mine. You can talk about stats because you can talk about pre- and post-test measures. So it's a variation. It's the multiple baseline design. I think the way to think about that is, if you're a clinician, to think about, what do I do with an individual patient? Basically, what you see there is what I think clinicians do. So they're talking about temperature, trying to drop temperature. They take temperature all the time. They put in an intervention. Does it get it better? Does it make it worse? And if I haven't emphasized, could I just do so again, that it allows for what's called additive components, that you can put in intervention A with patient 1, no treatment effect. Then you put in A plus B, still doesn't work. Then you put in A plus B plus C. You keep going till you get a treatment effect. And you do exactly the same with next either patient or the next treatment setting. You've got to replicate it in both. The disadvantage of this approach is that you've got to collect data, and frequently. And in the best of worlds, again using the example of the patients, if you're really sick, they're taking your blood pressure or your temperature continuously, so they get the data all the time. So that you don't have to work for day 1, day 2, day 3. You're getting it like every hour. If you could with this, you get the data every week, and then you can do the study really quickly. But if you don't have enough data, you might have to wait for longer periods. I'm not sure whether I explained that very well, but the data points, the size of the data points influence how quickly you can get it. So if you're just going using colonoscopies again, if you're in a hospital that does a lot of colonoscopies, let's say 100 a week, you can do this. If you're in a hospital that uses 1 colonoscopy a week, you can't, because you've got to collapse the data set to give you a better representation of what the hospital's doing. But again, any of the guys that I work with could tell you about this. They all are expert multiple baseline design. That it?
Yeah.
Okay.
There's just one final online comment from Tim saying that the community of practice will certainly have to look at some masterclass webinars on methodologies and statistics.
So thank you very much for attending. I must say that it's quite a spooky experience talking to some people here, some people with their slippers and coffee. But so thanks very much for your attention.